Hello everyone, greetings from Dr. Uma. Today we are going to present you this case of 26-year-old lady with previous 28 weeks preterm precipitate labor, due to which posterior part of cervix got torn and some part of it was missing due to tear. Hence we took decision of laparoscopic interval cervical encerclage. So as a routine procedure, before performing laparoscopy, we perform diagnostic hysteroscopy. So uterus cavity was normal and bilateral ostia were visible. So the port entry is standard. The main port inserted 2 centimeter above umbilicus and 2 left lateral ports and 1 right lateral port has been inserted. We performed 3D ultrasound also in this patient prior, just to confirm the possibility of future cervical incompetence. It showed cervical canal diameter approximately 1.3 to 1.4 centimeter from lateral side to side measurement in the coronal view. We performed chromoperturbation test to confirm tubal patency. So one assistant is sitting at the vagina and providing vaginal manipulation by inserting manipulated inside uterine cavity, which is not possible in case of pregnant cerclage, where we have to resort to blunt graspers for uterine manipulation. So the first step is opening of utrovesical fold adequately and dissecting bladder adequately so that we could pass the suture at the level of internal os just medial to uterine arteries. So the UV fold has been cut 0.5 centimeter below its attachment to the uterus. This is the area where it should be cut and bladder should be dissected from here. We have to dissect bladder just enough to allow easy passage of muslin tape here and to avoid future chances of bladder entrapment by muslin tape, as there has been some case reports of tape getting entrapped inside the bladder after perforating it. So we use polyester muslin tape with double-sided needle. The needle is half circle, but we have converted this needle into endoscopy needle so as to allow easy passage of needle from posterior to anterior. So we insert needle just above the level of uterosacral attachment, because uterosacrals get attached to cervix at the level of internal os, which is our primary goal and which is not possible to upload in case of vaginal encerclage. So the most common indication for interval laparoscopic cerclage are congenital short cervix, previous amputated cervix, previous failed vaginal cerclage such as McDonald's and High-Shirodker's cervical encerclage. So we hold the needle at the level of medial 3/4 and lateral 1/4 junction near the switched end. As the needle is heavy and little sturdy, so we have to keep a good grip over it and we have to insert it by looking at the tip anteriorly so that it does not damage uterine artery accidentally. So in this way we can allow easy passage of needle entry from posterior to anterior. After taking out both the needles anteriorly, we check posteriorly that we have inserted tape without folding it upon itself. So we correct the foldings and we check for proper level of entry of tape. So we have entered at proper level of internal os. After taking out needles, we cut both the needles at the end and we have kept them aside. Ideally, we should not keep needle inside the abdomen, as this patient was thin built and the needles are long and bit stout and we can easily localize them. we have kept them aside. So we take 4 to 5 knots just to avoid slippage of muslin tape. Some surgeons prefer taking bite from anterior to posterior. The both techniques are correct as long as we enter at the level of internal os safely without damaging uterine arteries. So after taking 4 to 5 knots of muslin tape, we cut the long ends and we take out both the long ends and both the needles. So the needles should be taken out safely by railroading them inside cannula and taking out cannula simultaneously with the needle. After taking out needle safely, we close the UV fold by polyglactin suture in continuous manner. In this way, we can avoid unnecessary exposure of tape inside the abdominal cavity. As we all know, pregnant cervical encerclage is always associated with minor risk to both mother and fetus, which is far lesser in case of interval laparoscopic cervical encerclage. The only disadvantage of interval laparoscopic cerclage is we have to remove the tape in case of intrauterine fetal demise or in case of preterm labor. So closure of uterovesical fold ends our procedure. The mode of delivery is always by cesarean section, and we can keep the tape for subsequent pregnancies. And after completion of childbearing, we can either remove the tape or keep it as it is. So this ends the procedure. Thank you so much for watching this video.